I have no disclosures, but what I'm going to talk about, and it's kind of based on both my experience and some evidence-based studies. Really, how do you make decisions in the current setting? And it's different for everybody. I think there are a lot of different ways to do this, but I thought I would start out and talk about this. First of all, looking at the evidence-based recommendations that are available to us, and then maybe talk a little bit about some typical cases. So I think I have about 30 minutes for this. Is that right? Yep.
You have long life.
So evidence-based recommendations are available for a lot of different sources. The American Heart Association is one, and the Stroke Council. Also, the Stroke Society of Neurology, the ANA, puts together guidelines as well. I based this brief discussion of the indications for aneurysm treatment on two of the most recent ones. The Guidelines for Management of Aneurysmal Subarachnoid Hemorrhage, which was published in 2012, and then the one published just over a year ago, August of 2015, for unruptured intracranial aneurysms. And I had the opportunity to work on both of those with a kind of all-star cast. You wake up and find yourself with some really terrific people, and what a great way to learn. So let me start with treatment of the ruptured aneurysms and the AHA recommendations. And so this is really distilled down. And when I went through these, what you should know is there are about 30 to 50 recommendations in these documents. And I tried to pick out the ones that are relatively new. The interesting thing about these documents is the day they're published, they're outdated because the technology changes so fast. And so a lot of the things that you're going to see here, we're going to talk about, really, I think the horizon's already changed. So basically what, the ISAT came out in 2004, 2002. And this, this ruptured aneurysm guideline was based, a lot of it, on that. And, obviously there was no data with stents or balloons in that trial. And ISAT was just for patients where there was equipoise between clipping and coiling, with no kind of a special techniques like aneurysms or stents. But basically, as you all know, it says if you have an aneurysm that can be treated either way, you ought to strongly consider, this is the way they put it, consider endovascular treatment. And that really means favor, I think. And an important aspect is you have to have a team of people who are experienced in both modes of treatment. So when is clipping favored? Well, I think it's pretty obvious for large ruptured aneurysms, middle cerebral artery aneurysms. What about endovascular coiling in the setting of subarachnoid hemorrhage? Well, for elderly, poor grade patients who would not be good candidates for clipping, and with basilar apex, I think coiling is clearly advantageous, but it wasn't so much seen at that time because there was no other data about that. But stenting of ruptured aneurysms, and that is until ISAT. Stenting of ruptured aneurysms was associated with increased morbidity and mortality because they couldn't be on antiplatelet agents. So this was only thought to be a alternative that you would use when other more risky options were were unavailable, or probably were not good options. So. Surgical clipping is effective for all unruptured intracranial aneurysms to an extent, but it was thought in this trial. But endovascular coiling was effective for selected UIAs. And that really goes back to the fact that there's about a 30% of the patients were thought to have equipoise for both. Patients who are selected for treatment should be informed of both. Endovascular coiling is associated with reduction in procedural morbidity and mortality, and that's really the reason why we favor it, as you all, I'm certain, know. This is what I wanted to get to, endoluminal flow diversion. this is a recommendation made in the Unruptured intracranial aneurysm paper, and it said that this is a newer treatment that may be considered in carefully selected cases. Well, you know, in some places it's being used so widely. I don't know about here, but I know, for instance, at Thomas Jefferson and the Mayo Clinic, it's really, I think, a first-line defense for these patients. But the patients that it's really FDA approved for are those who have aneurysms in the cavernous and periophthalmic segment, as you well know. So what is the pipeline device? Well, it's a flow diverter, and it's a 48-strand braided mesh. It was improved in 2011 after the PUFS trial, and there's a new device iteration called the Pipeline Flex, which has been a redesigned one. I hope I don't know if you covered this already, Cameron, in your earlier talks, so I don't want to be redundant, but some of this, yeah. So what's the difference between traditional stents and flow diverters? Well, it's really metallic coverage. If you look at the kind of the workhorses, Neuroform and Enterprise, they have only about 6% coverage, but Pipeline and other flow diverters, so some of the ones coming out of Europe, have 5 times, 6 times that amount of metallic coverage. The PUFS trial was a prospective single-arm 10-center trial where 108 patients were entered. They were really just trying to see if they could do it with efficacy and with safety. And they set a target for less than 20% major stroke and complete occlusion in greater than 50% of the patients at 180 days. The patients they studied were patients with wide-necked, i.e. greater than 4 millimeter aneurysms, saccular or fusiform, and they had to be in the petrous to superior hypophyseal, that paraclinoid, periophthalmic segment. And as a matter of fact, they well exceeded this. They had almost 75% of patients who were occluded within the first 6 months, and the major complication rate was about 5.5%. Between 6 months and 5 years, this is what was interesting to me. There were no ipsilateral strokes, neurological deaths, intraparenchymal hemorrhages, or subarachnoid hemorrhage. And that was surprising because we had heard a lot about complications from other centers in Europe in a delayed fashion. There were episodes of minor ischemic events, amaurosis, stenosis, but over 90% had angiographic cure rates at 3 and 95% at 5 years after the Pipeline placement. So it was thought to be a really good treatment for large giant aneurysms in that segment. If you compare the Pipeline results to Neuroform Enterprise, you can see it has a substantially greater obliteration of the aneurysm rate. And so I think that's what led to the use of this in certain centers. So kind of thinking about how do you make choices for your treatment type. So I like to divide it up really into 5 categories. I think most aneurysms could be treated in multiple ways, but I find it useful to, this is just the way I do it, to break them down into different groups. So aneurysms which I think favor flow diversion, those which favor coiling without a stent, those which favor coiling with a stent or with balloon assistance, those which I think favor microsurgery. And I still think there are some, and I'll be curious to see what some of our great leaders like Cameron and others here would say about, do they still think there are some that require microsurgery? I think there are, but I'm open-minded to this because goodness knows I've been proven wrong as I've tried to predict the future over the last couple decades. So those that favor flow diversion, what are the characteristics? Well, I think if you get a periophthalmic or cavernous sinus location, obviously the risk is high for surgery and the comparative risk for endovascular treatment is low. Also, obviously, stents are harder to use in the setting of subarachnoid hemorrhage, so unruptured or preferable. Larger size aneurysms are higher risk with surgery, so I think there's a relative advantage to them. And I'm going to show you some data later in my own experienced where that wasn't always the case. But I think for this segment, for the paraclinoid segment or the parophthalmic, it most likely is the case. And I think when there's symptomatic compression of the optic apparatus, or certainly the cavernous sinus, you can make a good argument. Now, that I think is very controversial, and I'm going to show you a couple cases later where I put in one case a pipeline and expected it to be less risk, and the patient thrombosed and developed a visual field deficit. And in another case, a very similar ophthalmic artery aneurysm where I did it the traditional way and his vision actually improved because we decompressed it more acutely. And the argument remains, if you look in the long term, what we probably ought to do is create, with all the data that's available and what Steve was showing me with the access to data here from around the world, we could very quickly figure out, in all likelihood, which would be over a period of time, 6 months or a year, which one's going to be better. Advanced age, obviously, because the surgical risks are high, and high risk surgical treatment for other reasons. So risk factors which disfavor flow diversion. Well, my own feeling of this is that midline aneurysms, where I think the perforators are so unforgiving, particularly the basilar tip, the basilar apex, and even the ACOM, obviously more forgiving, but still the ACOM I think is often underestimated, and I'm curious to see how the flow diverters are going to perform in the anterior circulation. I know there's more and more evidence coming out now. So I think the perforator pattern is less forgiving in the midline, and compared to, say, the ophthalmic, where there's a more forgiving pattern, the midline ones are higher risk. So here's an example of an aneurysm. I showed this at the academy, and it came out that week, where flow diverters, I think, can be higher risk than standard microsurgery. So this was a middle cerebral artery aneurysm that was treated live in one of these internet sessions, and really I think was a fairly straightforward MCA aneurysm for surgery. And so I think in this particular case, they took a rather straightforward microsurgical case and turned it into a complex one. And perhaps as the technology gets better, that's going to be less the case. But I think right now, I still think that this is a relatively straightforward surgical case. This was a table that they put in here, where a number of different centers are doing this. First of all, they coiled here, and then they came back because of recurrence, and they put in a flow diverting stent. And they accept that one of the branches is going to close. And I've seen this, in my own experience, that sometimes when they close chronically, they're well tolerated. The closure surprises me. This is one of the things I've been surprised with. You think you can't lose one of the left MCA branches in most people, but in fact, you often can. But I still think that it's a higher risk problem. And if you look at the neurological deficit, 43, 16, 16, 27, 18%. And what's interesting, though, is they say morbidity, which is always lower, 0% here, right? And 0%. I'm not sure quite how that works when there's, how they count neurological deficit but with no morbidity. But the point of the matter is it's being done very aggressively in Europe. And I think we'll have some time hopefully to talk about this to see others' point of view on this. Cases suited for simple coiling, I think this is pretty straightforward. Ruptured, narrow neck, basically any narrow necked aneurysm, ruptured or unruptured, I favor, like probably everyone else, endovascular treatment, because what's the disadvantage? It's durability. A narrow neck, it's going to be a very durable treatment in all likelihood. Advanced age obviously favors coiling. We talked about the locations, basilar apex and trunk, parophthalmic. The one that, I don't know if many have seen this, but there have been a number of studies that looked at cognitive outcome. And cognitive outcome, although pericallosals are not hard and they're fun to do because they're different, the cognitive outcome is better with endovascular in a number of small studies. So I think that's one where I favor endovascular treatment as well. Indications for coiling without stent is really, well, I should say factors disfavoring it is where durability and recurrence is a major concern. So young patients, larger aneurysms, wider necks. If you look at the ISAT trial, almost half of all the recurrences happened at the PCOM location, but no, I guess new news, the large and giant aneurysms were the ones that recur. And there's also data out there to suggest that it's, in fact, from our institution, much higher in smokers. Cases suited for stent coiling, you know this as well. And honestly, this is an area, my experience is where the aneurysm field has expanded. And I'm going to show you a case pretty soon. This is it actually, of a large, I think it was 17 millimeter basilar tip in a 67, 69-year-old woman. One who we would have thought of as a very high-risk patient surgically. Wide neck, perforators off the back of it, elderly woman, big operation. But a stent coiling operation, in my experience, has been a very low-risk candidate. I'll come back to that later. So factors which disfavor subarachnoid or disfavor stent coiling, again, subarachnoid hemorrhage, any endovascular treatment. Very difficult access, type 3 arch, FMD. I think I saw Cameron had a case up a few minutes ago, and I think which I forget which type of FMD is, but there's a very, very high dissection risk, about 50% in I think it's type 1. Don't quote me on that because I need to check it before I tell you the number. Small distal branch vessels, obviously that's a problem for stents if you don't have a good target vessel, and renal insufficiency. So intolerance to antiplatelets, reasons that anyone would not want to do endovascular treatment. What cases favor microsurgery? Well, I think larger ruptured aneurysms, MCA location like we just talked about, and then certainly there's good evidence to suggest that aneurysms with large clot. Now, again, there are centers that are coiling these and then taking the patients to the operating room. I think that is a sequelae of the training pattern shift, because it just seems to me that the most efficient, fast, good way to decompress the brain ought to be to take the clot out and clip the aneurysm at one setting, particularly for big clots. But I'm kind of amazed when I see a lot of places will coil first and then go take the clot out. And I always think it's the clot that's problematic in those patients, so I really favor getting it out first. Risk factors for recurrence: wide neck, PCOM location, young patient, smoking history like we talked about. Factors disfavoring microsurgery: high-grade subarachnoid hemorrhage, we talked about that, grades 4 and 5. Patients, again, this is where endovascular treatment has widened the treatment envelope for patients, because I think for a long time we didn't treat those high-grade patients in many centers because the results were so bad. But with endovascular treatment, I think that a lot more patients are getting treated. Maybe not grade 5, but a lot more grade 4 patients are getting treated now. Calcified neck and dome, those are obviously patients who are at high risk for complication with clipping. And then we talked about location again. Are there truly cases requiring microsurgery? I hope to show you today. I think there are a few. Obviously, we talked about aneurysms with big clots, but there are other situations as well. Fusiform giant aneurysms with one inlet and 2 or 3 vessels literally coming out of the aneurysm. Could you Y-stent them? Possibly, but many you can't, particularly in the ACOM, where I think the angle of approach would be very, very difficult for most patients, and perhaps MCA too. Again, this is something I'm anxious to see from Cameron and others, that they're going to dispute that, because I'm sure there are in some cases where it's possible. Ruptured dolichoectatic fusiform aneurysms, again, that's a situation which is rare, but does happen. So I'll give you one example. This is, again, a patient that was treated some time ago, but a 29-year-old right-handed woman, 10 days postpartum after an acute subarachnoid hemorrhage with intracerebral and subdural hemorrhage from a giant ruptured left MCA fusiform aneurysm. I don't know if you can see it here, but the M1 segment is long, first of all, so the perforators are coming off proximal. And even though it's in the typical location, it has a big crescent shape. There's a little lucency there. This was actually the best way to separate them, but it goes in here and comes out there. And she has a elevation of the segment here because there's a big clot in the bottom of that. She needed urgent clot evacuation. She actually had a herniation episode, and she had basically, we had to take the clot out and cut out the aneurysm and reanastomose the vessel because it was completely useless. But again, look at here's the anastomotic side, and look at the perforators. We were lucky; the perforators were all clear, and she was 10 days postpartum. Here she is a year later, holding the baby with her right arm. So sometimes I think it is useful, and I don't think that patient would have been treated. There could have, even today, I don't think there would have been a good alternative for that person to have endovascular treatment. So a summary. Well, I think coils and clips remain the mainstay of treatment at most centers, certainly with prominent exceptions. Well, I've already named a couple. And endovascular coiling is absolutely preferred for any narrow-necked aneurysm, ruptured or unruptured, and high-grade patients as well. Well, grade 1 to 3 and high grade, I think, if you can do it. I would not treat a grade 5 patient usually myself, unless I thought there was some indication that they were, better. What might that be? For instance, a clot in the fourth ventricle that's compressing the brainstem, where they look neurologically worse, perhaps, than you expect them to be in terms of their recovery. Patients, as you know, who have brainstem compression from a clot can make a lot better improvement neurologically than patients with the same kind of brainstem signs who don't have a clot. So older patients with high-risk unruptured wide-necked aneurysms, we showed you those. I think those are really well served by the stent, by the possibility of using stent coiling. As you know, the braided coil, the pipeline, is not yet approved for the posterior circulation. It's been used. I'm going to show you a case later where we used it ourselves, and I think it can be useful, but it's currently not approved. And so if we're going to talk about FDA approval, we'd have to exclude that. Microsurgery is still the mainstay for ruptured MCA, at least in this continent, and wide neck PCOM and ACOM aneurysms, particularly in young patients who smoke, where the concern for recurrence is high. And flow diverting stents, the pipeline in North America, can have limited approved indications, but I think everyone feels the trajectory of the technological improvement for these flow diverting stents is impressive. And you may or may not know, you may have heard, I'm sorry I missed earlier today, but there's going to be data coming out in 2017 in regard to this. And I think, I don't know, but I think some of that data is going to show that flow diverting stents have a wider use than what they're approved for right now.